Hi, this is Teshamae Monteith. I am an associate professor of clinical neurology and on the editorial board for the American Migraine Foundation. It's such a pleasure to host this webinar on migraine and COVID. So I would like to thank the American Migraine Foundation for their insight and their leadership in allowing us to have this discussion. With me today is Dr. Chia-Chun Chiang. She's an assistant professor of neurology at Mayo Clinic in Rochester, associated with the headache division as well as vascular neurology, as well as Karyn Bishof. She is a very active advocate and also an unfortunate sufferer of long haul syndrome. And she's founder and director of the advocacy for the Longhauler Advocacy Project. I want to hear all about that. So we have a great discussion. We're going to start off with Karyn's story. I think it's always important to start with the patient, and then we're going to have a clinical discussion about migraine and COVID-19, followed by questions and answers. Before I do that, so many of us has been affected by COVID-19, either by an illness individually, a loved one that has passed away, and in particular the migraine community. Many patients have been suffering, and so it's so important that advocacy is at the forefront of this whole fight, because even though many of us want this pandemic to be behind us, there are many people still with lingering symptoms. So the Alliance for Headache Disorders Advocacy in February had a panel discussion in Congress, which resulted in several recommendations about how to approach this problem, both clinically and most importantly, research-wise. So there is a link that will be available if you want to read that report. So I want to start with Karyn. How are you?
Hi, thank you so much for having me today.
And I just want to, I think everyone should know that you came on at the last minute. I gave you very little kind of heads up and you were able to do it. And that's the kind of fighter that you are. So I really appreciate you being on here.
Thank you. I appreciate the opportunity and to speak on behalf of some of the struggles of not only myself, but the long COVID community. So hello, everybody. My name is Karyn Bishof. I am a long COVID patient since March 2020 and infected while working as a South Florida firefighter paramedic. I am the founder and president of the COVID-19 Longhauler Advocacy Project, which is a nonprofit dedicating to advancing the understanding of long COVID and its associated conditions and expediting assistance and solutions to long haulers and their families. I currently serve on the NIH's Recovery Initiative's Ancillary Studies Oversight Committee and was just appointed to the National Academies of Sciences, Engineering, and Medicine's Committee, tasked with examining the U.S. government's working definition of long COVID. COVID-19 Longhauler Advocacy Project is also a co-drafter with Representative Ayanna Pressley of the Treat Long COVID Act. Prior to my COVID-19 infection, I was healthy and would rate my overall health a 9 out of 10. I was an active single mom, still playing soccer, and a firefighter paramedic as noted before, and working out doing high-intensity interval training 5 to 6 days a week. On March 15th of 2020, I developed a sore throat and from there on out continued to develop other symptoms along with coworkers. I had a mild to moderate case, which I was not hospitalized for and did have access to testing, which many at the time did not have access to. I was later terminated from my job as a firefighter paramedic, and I have not been able to return to work since and have put my efforts into advocacy for the tens of millions suffering with long COVID like me. While I had a mild to moderate case of COVID and had a brief period of feeling like I was getting better, between weeks 5 to 8 post-acute infection, symptoms again ramped up and new ones began to occur. After years of now being an advocate in the long COVID and chronic illness space, and as a leader of the long COVID organization, I have learned a lot about post-viral illness, its history, and what the future looks like for many without research coming through for us, which, by the way, 1 in 5 that get infected with COVID-19 develop long COVID. Long COVID is an umbrella term that encompasses many different symptoms and conditions post-COVID infection, which can last months, years, or potentially life if research cannot identify a cure. My version of long COVID has left me with postural orthostatic tachycardia syndrome, which is a form of autonomic dysfunction and one of the most common diagnoses post-COVID. It has also left me with ME/CFS, mast cell activation syndrome, fibromyalgia, small fiber neuropathy, eosinophilic esophagitis, lots of GI issues, and cognitive impairment, and what we're here to discuss today, new daily persistent headache and migraine. These conditions occurring post-COVID are known as long COVID-associated conditions, as we help define along with HHS in their recent reports on long COVID. Since around the first week of getting COVID back in March 2020, I've had a headache virtually every single day in some capacity, and I'm not unique in this regard. According to a 2020 article published in the Journal of Headache and Pain, headache is among the most common symptoms that present during acute phase of COVID infection, affecting up to 60% of people, as well as one of the most frequent symptoms persisting or newly developing after COVID-19 infection. In the long COVID phase, headache is now considered the 5th most common symptom, and this can refer to either a new onset headache or a worsening of a pre-existing headache. Although research on COVID headaches and the community, as the community refers to them, is still extremely limited, the growing understanding is that COVID headaches are caused by persistent activation of the immune system in some way. COVID headaches, as the community refers to them, can follow a migraine pattern or present as a tension headache, and they're typically experienced as daily persistent headaches. This ongoing presentation, along with its lack of response to typical headache treatments, make COVID headaches one of the most debilitating symptoms long haulers can experience. In my own experience, my headaches seemingly have no given trigger because they occur even when at rest, even after days of rest. It is incredibly important to note, however, that headaches are commonly triggered by physical and/or cognitive efforts and can be a major aspect of post-exertional malaise, which is a hallmark symptom in long COVID patients. I suffer from migraines both with and without aura, often leaving me seeing green and purple in my vision along with blurriness. I have gone through a massive amount of medications to try and address my headaches and migraines, and it can be a rather hopeless feeling at times to burn through so many without relief or return quality of life. From gabapentin to nortriptyline, amitriptyline, Fioricet, Aimovig, sumatriptan, Botox, Emgality, topiramate, and more, I continue with severe migraines and headaches that significantly impact my quality of life and activities of daily living, causing disability, which as a single mom is detrimental. Heat, which is a problem when you live in South Florida, light, sound, smells, physical or cognitive activity, certain foods, and of course stress all contribute to migraines. One of the biggest triggers I personally have is simply being upright, which is a result of my autonomic dysfunction and result from sitting or standing. However, laying down too long can also trigger headaches, so finding a happy medium is hard, if not impossible to do, especially when you have multiple comorbidities. When I have migraines, I feel as if I am burning up even though I don't register a temperature. It is a throbbing and global and/or around the crown of my head. Any movement of my head or eyes is unbearable and often will cause me to become severely nauseous and vomit. I feel overall extremely weak and shaky. I'm often left in this state for 2 to 3 days at a time, and it also leaves me on a liquid diet. I almost never have lights on, have blackout curtains, screens dimmed, protective sunscreening on my car windows, and the darkest sunglasses possible. I'm incredibly sensitive to sound and more recently have been dealing with what seems like vestibular issues, which are pending testing. I cannot read anything more than a couple of pages long and deal with extreme nausea and vomiting if trying to do so. Making simple phone calls is something I procrastinate on. Even just a couple of minutes will trigger the start of a headache or migraine. I have had brain MRIs and MRAs which show up normal, and we continue to plug away at anything that can help reduce my headaches and migraines. While there are many studies ongoing surrounding long COVID and media publications about the conditions and symptoms included with long COVID, there has not been enough focus on headache and migraine conditions, especially given the percentage of patients within the long COVID community experiencing them. As patients, providers, and researchers work to treat the long COVID population, I stress the need for cross-community and cross-specialty collaboration on research and patient care, as long COVID is multi-systemic. Long COVID is a mass disabling event that will leave large impacts on the patient community, the public, and an already burdened medical system. Migraine and headache conditions deserve and need more recognition in long COVID, and I am happy to see that ongoing today. And I will end with saying, if there is anybody here today seeking support and resources for long COVID, you can join us at longhauler-advocacy.org. Thank you.
Thank you, Karyn. That was amazing, and you really set the stage for the later discussions that we're going to have. It's really important to see that patient face, because science is so much without the patient face.
Thank you so much.
Okay, Chia-Chun, do you want to pull up your slides?
Yeah, sure. Yeah, thank you so much, Karyn, for sharing your story. Certainly emphasize the need for more research going into how to treat these headaches and more understanding of the pathophysiology of a headache associated with COVID-19. So hi everyone, my name is Chia-Chun Chiang. I'm a headache specialist and also a stroke specialist at Mayo Clinic in Rochester, Minnesota. Very honored to be here today to share with you and talk about headache in patients with COVID-19. Next slide. So as Karyn shared, headache is indeed a very, very common and disabling symptom of COVID-19. Whenever we talk about headache associated with COVID-19, we can think about, so first is headache attributed to COVID, the SARS-CoV-2 infection, and there are several different phases. So in the acute phase typically refers to the headache that starts anytime between the COVID symptom onset to week 4. Post-acute phase typically refers to from week 5 and onward, and there's this ongoing symptomatic phase from 5 to 12 weeks, or more than 12 weeks if the headache persists for more than 12 weeks, which is a story that Karyn shared. It's referred to post-COVID condition or long COVID syndrome, with Dr. Monteith. We'll discuss a little bit further later in the presentation. Other things that we need to consider is sometimes for headache associated with COVID-19, there are certain secondary headache disorders. So for example, there are several vascular conditions like cerebral venous sinus thrombosis, which is a blood clot in the brain, or certain vasoconstriction syndrome or certain types of stroke that have been reported to associate with COVID-19. So that has to be ruled out with MRI and some vessel imaging as well. Another thing is the effect of COVID-19 infection or the pandemic on pre-existing primary headache disorder. So for example, a lot of patients had migraine before the pandemic, and now after either a COVID infection or stress associated with the pandemic, the migraine gets significantly worse. So that needs to be addressed as well. And then lastly, there's also headache attributed to the SARS-CoV virus vaccination that we will discuss as well during our presentation. So next slide. These are several numbers that we put together on headache associated with COVID-19. For the acute phase, headache is typically reported in around 50% of patients can have headache with COVID infection. As far as after the acute phase, headache is reported to be around 30% of patients after 1 month after COVID, and after 9 months, it goes down to about 16%, per some studies that reported in the literature. So for both acute and post-acute phase, of a headache that occurs in the acute and post-acute phase is more commonly seen in females. And in the acute phase, headache is more common in younger patients versus in the post-acute phase, headache is more commonly reported in kind of older patients. And primary headache disorders like pre-existing migraine is more common in patients that had headache in the acute phase after COVID-19 infections versus for those who had headache in the post-acute phase or long COVID infection. There's really no significant association between a history of migraine or history of pre-existing primary headache disorder with persistent headache that still occurs at 9 months. In terms of the headache characteristics, patients report that headache can be pressing, throbbing, moderate to severe in intensity. Most patients report that it's severe, up to 90%. Most patients report that the headache is bilateral, 85% in the acute phase and 70% in the post-acute phase. And some patients also have photophobia, phonophobia, kind of migraine-associated or migraine phenotype symptoms as well. So the clinical feature of headache associated with COVID-19 is similar to either tension-type headache or migraine-type headache. There are also studies that report that several symptoms can be associated with headache. For example, in the acute phase, loss of smell and loss of taste has been identified as symptoms that significantly associate with headache that occur in the acute phase after COVID-19 infection, versus in the post-acute phase, fatigue, brain fog, insomnia are symptoms that have been found to be really significantly associated with headache, with persistent headache after a COVID infection. Next slide. In terms of possible pathophysiology or the cause of headache with COVID infection, again, this is an area that we need more research to kind of identify the reasons and the possible causes of headache. There have been some research and some theories, but there's not really like a firm known answer to this question yet. But here are the proposed pathophysiology of headache. In the acute phase, it is thought to be related to the activation of the trigeminal vascular system, which plays a key role in migraine pathophysiology. And that can be by local or systemic dysregulated inflammatory signals like cytokines. There is also some studies suggesting that there might be direct viral damage to the trigeminal vascular system. However, there are some debate and controversy around that theory, so that's why I put in a question mark there. In the post-acute phase, it is still thought to be persistent activation of the trigeminal vascular system related to inflammation, and sometimes there can also it can also involve a process called central sensitization as well. For post-vaccination headache, it is thought that fever and meningeal sensitization by TNF-alpha could be associated with vaccine headache that occur after vaccination. There are also some interesting studies specifically on headache after COVID infection. So for example, one study is regarding the headache prevalence on by different COVID variants. So one study reported that patients that were infected by the Delta variant have a higher likelihood of developing headache after COVID infection compared to patients that were infected by other earlier variants, such as Alpha variant, which suggests that different types of SARS-CoV variants might act differently on the nervous system. And that could be an explanation of why patients affected with different variants might have different headache presentations. Interestingly, a recent study also pointed out that headache could actually represent a marker of a host defense mechanism that could be associated with enhanced COVID survival. And this theory is based on a meta-analysis of 48 studies, which include 43,000 patients with COVID-19 that reported there is actually a higher survival rate among patients with COVID that were admitted to the hospital in those with headache. So for those infected with COVID that had to be admitted to the hospital, patients that had a headache actually had a higher survival rate compared to patients without headache, which the headache might actually be a presentation of this body defense mechanism. But this theory certainly needs more studies to confirm this theory. Next slide. In this table, we summarize the headache ratio, the ratio of headache that occurs after different types of SARS-CoV-2 vaccination. And next slide. Overall, the summary is that, oh, sorry, go back to the previous slide. Yeah, so it occurs in about 40% of patients, and for some vaccinations, it is more common after the second dose, and for other types of vaccines, it is more common after the first dose. Next slide, please. But in general, headache associated with SARS-CoV-2 vaccination is mainly mild and typically resolved within a few days. And notably, we got a lot of questions on whether the migraine treatment should be postponed or delayed or rescheduled related to COVID vaccination. But it is important to emphasize that currently we don't have any evidence that migraine treatments such as CGRP monoclonal antibodies or Botox injections need to be delayed or rescheduled because of the timing of COVID vaccination. Next slide, please. In terms of treatment associated with COVID-19, again, this is an area that needs more research on to study specifically treatment for headache associated with COVID-19. But here are several studies that reported that for acute treatment, there can be potential improvement with corticosteroid, reported by about 40% of patients from a case series. Another case series suggested that greater occipital nerve block could be helpful for those who previously did not respond to oral medications, such as acetaminophen. Some patients reported response to indomethacin, and there's various response to triptans, which is a migraine-specific acute medication. In terms of vaccination-related headache, NSAIDs or acetaminophen were the most commonly used, and aspirin were among the best rated medication, over-the-counter medication for certain vaccinations from several studies reported. As far as preventive treatment, it is typically we treat according to the headache phenotype, let's say for either migraine, headache, or tension type headache. And importantly, a lot of studies reported that many patients experience what we typically see as what we call chronification from episodic to chronic migraine. So some patients that might first develop episodic migraine after COVID infection, but it can progress and develop this chronification to chronic migraine. So they might develop more frequent headache with time. So it is very important to intervene early and treat aggressively to reduce the possibility of developing more frequent or chronic migraine after COVID infection. In the treatment of headache associated with COVID-19, it's always very important to remember that we should avoid medication overuse, meaning that sometimes if we use an acute headache medication, either over-the-counter medication or triptans, if we use it too frequently itself, it could potentially cause medication overuse headache, causing worsening headache. So that's always something to remember when we treat patients with headache associated with COVID-19. Next slide, please. So talking about headache and the COVID-19 pandemic, it is also important to mention the development of telemedicine. So one good thing with the COVID-19 pandemic is that it really pushes the quick adaptation and utilization of telehealth technology. This picture that we see on the right-hand side is a study from a VA health system suggesting that in-person visits significantly reduced or declined since March of 2020. However, video visit and telephone visit use have increased significantly since the pandemic. So it really improved access to care for a lot of patients. And several studies or surveys have also suggested that it can be satisfactory to both clinicians and patients. And some studies also reported that typically clinicians now prefers more so in-person appointment for the initial encounter or initial consultation to have a better understanding and relationship to patients, and telehealth can be utilized for future follow-up visit. However, there are several things that still needs to be addressed with all this telemedicine and telehealth utilization. So for example, disparity in access to care still exists when we compare the utilization of telehealth in urban urban area versus rural area, and different race, ethnicity, and different kind of comfort level to technology that all needs to be considered and needs to be improved upon. Next slide. So last year, I also worked with the American Migraine Foundation, and we did an online survey of patient experience of telemedicine for their headache care during the COVID-19 pandemic. We asked overall, how would you rate your experience using telemedicine for your headache disorder care and treatment? Over about 23% patients rated their experience as very good or good. And we also asked, would you continue to use telemedicine visit for your headache care and treatment? About 89%, almost 90% patients said yes or yes, but not for all visits. So certainly, hopefully telehealth and telemedicine will continue to be available for a lot of patients for their ongoing headache care, as patients have reported very satisfactory responses to utilize that for their headache care. Next slide, please. Yeah, so that concludes my presentation, and then we'll hand it to Dr. Monteith.
A lot has gone on in the past few years. This is the Johns Hopkins tracker system. I used to check it pretty regularly. As of March 10th, they actually stopped tracking COVID-19. Not that it's gone away, but that it's become endemic. And if you look at global deaths, 6 million, close to 7 million deaths worldwide. So tremendous. Most of these deaths were associated with the original COVID-19 strain, as well as the Delta strain. And when we think about long haulers, those initial infections of COVID-19, those are the ones that have the highest prevalence. Not that it's not frequent with Omicron, but that most pronounced with Delta variant. Next slide. So just some definitions of post-acute sequela of COVID-19. This is according to the definition of the World Health Organization, usually occurring within 3 months and lasting for at least 2 months. And many of these symptoms may happen in clusters. They can relapse, they can fluctuate. A patient can get better, and then there can be a worsening of symptoms, which can sometimes lead to confusion. Next slide. So long COVID is really a symptom complex. And when you look at this Venn diagram, you begin to understand the complexity associated with COVID-19 and migraine. Firstly, some of the associated symptoms of migraine itself are symptoms that are common to long COVID, for example, brain fog. And when you think about some of the comorbidities associated with migraine and some of the risk factors for progression, such as anxiety or depression, these are also symptoms associated with long COVID. Dysautonomia, for example, can, as we know, complicate migraine. Is a prominent feature of long COVID, as Karyn had mentioned. And also some of these symptoms can complicate our treatment options. As we know, amitriptyline, which is a drug commonly used to treat post-COVID headache, can aggravate fatigue. Topiramate can aggravate brain fog. And so it becomes a very complicated problem. Next slide. And so this was a survey, an international survey that was recently published that looked at or tried to assess both neurologists and non-neurologists' confidence with the diagnosis of neurologic complications associated with COVID-19, and as well as the definitions itself. And based on the survey, it seemed like there was pretty good agreement on the definition and also the diagnostic accuracy associated with these complications. However, by and large, long COVID was underestimated, as well as altered mental status, which can be a source of confusion for clinicians, both neurologists and non-neurologists. Next slide. So this is the NIH Recover research study, and basically it shows what we know from COVID infection itself, that there are these disparities. There are socioeconomic disparities, but also racial and ethnic disparities that are really important. And these disparities are not just happening during the acute infection, but are also occurring during long COVID as well. So this is, you can certainly take a look at this reference, but basically it's showing you in many of the systems that in comparison to whites, that Blacks and Hispanics have higher rate of many of these systemic problems that are associated with long COVID. So, when we tackle this problem, we really have to think about health systems, and it's really COVID-19 has uncovered quite a lot. Next slide. And so headache is a common manifestation, has what was mentioned, associated with long COVID, both in the midpoint as well as longer periods of time. This occurs in both hospitalized patients as well as outpatients. Next slide. And so when it comes to prevalence, and this was a large meta-analysis of over 10,000 patients, and it showed that the prevalence of headache was about 15% according to this meta-analysis. And if you look at some of these other symptoms that are associated with long COVID, again, this interaction with brain fog, anxiety, sleep disturbances, you can see how it could aggravate migraine. Next slide. And the duration of symptoms. This was a study that looked at, again, the midpoint, the same study, but now looking at duration of symptoms, midpoint as well as long-term symptoms. And when they assessed patients in a shorter interval of time, headache became increasingly common during follow-up. If you look at all these symptoms, cognitive dysfunction was actually the most common symptom, both in the early phase as well as a more long-term phase. So anxiety and depression increase significantly over time. So this is a way to just kind of assess patients, and I think it really brings about a point that you may see a patient shortly after COVID-19 infection, 3 months, but if you follow them up in 6 months, you may have a higher amount of patients that are reporting headache and other symptoms that were not diagnosed early on. So it really requires a continuous assessment. Next slide. And this is the INSIGHT cohort. Basically, it's a data-driven identification method for PASC and trying to identify subphenotypes. And this is nothing for you to memorize. This is headache here. But I think it's a nice way to use this exotic kind of heat mapping method to cluster patients with different PASC phenotypes. And so we're not at this point yet, this is strictly observational, but at some point it would be nice to really be able to find some data-driven method to be able to classify our patients and then, of course, get those patients into clinical trials and determine what the best treatments would be for these patients with these subphenotypes. Next slide. And this was already discussed. Headache is actually a pretty common symptom of vaccination, and it's actually a symptom that you want to have. It's a symptom that shows that your immune system is responding to the vaccination. But by and large, most patients' symptoms are mild, with very rare cases that are considered moderate or severe. And this is the most common vaccines. The mRNA vaccines, both Pfizer and Moderna, as well as the Johnson & Johnson vaccine. And interesting that, as was mentioned, for the mRNA vaccines, it seems like those two consistently seem to have a little bit more headache. So it's just a matter of educating patients that, yeah, you may get headache, it may be mild, bring your medications with you, and you should always bring your medications with you if you have migraine. Next slide. So, vaccination, it's an important thing to get. And this was a study out of Israel that showed that individuals that were vaccinated were less likely to have long COVID symptoms. Next slide. And so, so if you look at B's for headache, so it's right here. And when comparing patients that had vaccination, 2 doses of vaccination versus unvaccinated, there was a numeric difference in symptoms of long COVID, and in particular headache, but it was not significant. There were a number of significant symptoms. Headache wasn't one of them, but you can imagine that it follows this trend. And I think what's most important is that the vaccine certainly does not increase long COVID symptoms. Next slide. So, you know, how do we manage long COVID? I think there's a lot to learn, and it's certainly something that we benefit from talking to each other as clinicians in settings like this. You have to get the diagnosis of COVID-19. You have to ask about it. Not everyone gets tested, so obviously that's a problem, but the first step is getting the diagnosis of COVID-19 and then identifying long COVID. As mentioned, some patients may not have symptoms early on, but later on develop symptoms. It could present at 6 months out, which goes against the World Health Organization diagnosis. Next slide. And the main thing here is that it does really require continuity of care, and for some patients that have multiple systemic symptoms, multidisciplinary care. Next slide. And so this is a great summary, and just, you know, I wanted to use this as a reference, but this is, you know, we just don't have a lot of data out there. And, but, you know, there's some things that maybe can be considered for patients that have dysautonomia. A stellate ganglion block may be of benefit. Patients may also benefit from beta blockers. Antivirals may be of benefit. That is something that is being currently evaluated. So GI symptoms, probiotics have been suggested as a potential possibility. Next slide. And we talked about POTS. And interesting, patients that have cognitive dysfunction, maybe some of these patients may benefit from post-concussion type protocols to improve their well-being. For fatigue, that's a really difficult problem. It's unclear. Again, we just don't have the evidence for this. It's been suggested to try things like CoQ10. For pain, fatigue, low-dose naltrexone has been also recommended. Next slide. And so treatment of post-COVID headaches, we do need randomized controlled trials. I want to emphasize that we really just don't have that. There have been a small number of retrospective studies, one study of 48 patients suggesting that amitriptyline may be useful for patients. In patients refractory to simple analgesics and triptans, indomethacin was highly effective for these patients. And so, you know, as was mentioned, it's going to be about symptom management, assessing a patient's disability to see whether they would benefit from prophylactic therapies. And we don't want to aggravate symptoms. We want to improve symptoms, not just headache, but other symptoms that might be associated with this systemic problem. CGRP monoclonal antibodies, or GPANs, have been suggested to possibly benefit patients that are presenting with headache or migraine-like phenotypes. Next slide. And so there are just a number of clinical trials. I just looked at clinicaltrials.gov just today, and it's just we don't have enough where headache is an endpoint. Antivirals has been suggested for post-COVID-19 condition, and there's a current clinical trial going on now. Transcranial direct current neuromodulation for patients, SVG blocks versus placebo, and then vagal nerve stimulation, where headache is one of the outcome measures. Next slide. So in conclusion, post-COVID-19 headache is common. It's often associated with a complex phenotype associated with non-headache symptoms, which adds to its disability. After years dealing with the COVID-19 pandemic, we still don't know enough about triggers, recovery, and relapse for post-COVID-19. Headache is a really important core measure associated with clinical trials as well as definitions. So kudos to Karyn for plugging that in. And then, of course, we need more multi-center studies that evaluate headache, identify targets, and develop evidence-based approaches for our patients. And that's it. Thank you so much. I think we have a little bit of time. Please put your questions in the chat. And while we're waiting for those questions to come out, I guess I'll go back to Karyn and ask her, from these presentations, what do you take away with it, with your personal story?
Just again, that, what we refer to as these post-COVID headaches are really not on the forefront of a lot of the research going on, and that a lot more advocacy in terms of post-COVID headache, a lot more providers being able to speak up and organize research is so important to the patient community, because post-COVID headaches are completely debilitating. Like I mentioned before, a lot of the typical therapeutics used for some of these conditions are not necessarily working as effectively, if you will, in long haulers, and a lot of that is because of the number of comorbidities that you see under this umbrella of long COVID. And even, as Dr. Monteith mentioned, taking medications for some of these other comorbidities may have side effects that are affecting your migraines. So, one of the things that I deeply struggle with is insomnia, and I know that that affects my migraines, but we haven't been able to find a solution to that. So there's this domino or chain effect, if you will. And again, that's why I emphasize it's really important, I think, in terms of research. Like when you see headaches also being some of the most common symptoms in a lot of the comorbidities that make up long COVID, like dysautonomia and mast cell activation and some of these other conditions, it's important to recognize that we have to treat the whole patient and recognize the overlap in so many of these.
Yeah, great point. We do have one question here that is asking whether migraine may predispose an individual to more severe COVID infection, and the answer is no, as far as we know. And there was even some suggestion that it may even be something that is of evolutionary advantage. My own criticism with that is that if you've ever read the charts on these patients, some of them are so sick in the hospital and they may not be reporting headache. And then the other question is whether a migraine may predispose to post-acute sequela of COVID-19 or be associated with long COVID. Do you want to take that one, Dr. Chiang?
Yeah, post-COVID aggravate pre-existing migraine. Yeah, I think, yes, so there are a lot of reports that patients with pre-existing migraine, their headache can get worse after COVID infection, and that includes patients who had developed post-COVID syndrome. So certainly, yeah, pre-existing migraine could certainly worsen with a long COVID syndrome. And I think there's a question for me. Can you say more about the chronification of migraine post-acute phase? Post-acute, there's been an increase in the number of migraine going from episodic to migraine. Can you clarify what point migraine is considered chronic? So, yeah, so some literature, some studies have reported that, for example, for patients with episodic migraine, typically refers to patients who had headache less than 15 days per month, and after COVID infection or after a period of time after COVID infection, their headache can increase in frequency and severity. So that's typically refers to chronification of migraine. And chronic migraine is defined as having headaches more than 15 days per month for more than 3 months. So that indicates a persistent or consistent increased frequency of their headache.
Yeah, unfortunately, we really don't have good data that shows that patients with COVID-19 have a higher likelihood of transitioning from episodic migraine to chronic migraine, but I think we're seeing that in our clinics where our patients are coming in, they were well controlled, they got COVID-19, and at least a subset of patients develop chronic migraine or well, they used to have controlled migraine, and then it relapses back to chronic migraine. And that, I think, is in line with the World Health Organization definition. So Melissa has a question about Paxlovid on longer-term increases in migraine, particularly for people diagnosed with chronic migraine well before COVID-19 diagnosis. So I'm not sure of the question, if I understand it correctly, if you're asking whether Paxlovid may increase migraine or whether it may reduce the risk of persistent headache. I think I've not seen in my clinic where patients that have used Paxlovid then have resulted in worsening migraine symptoms.
Yeah, me too. I have not seen migraine or worsening migraine directly related to Paxlovid medication. No.
Yeah, so if you need it, take it.
I see a question from Iris that I can take. So she says, is it possible to have a delayed migraine response after COVID-19 infection? In other words, can long COVID develop months after initial COVID symptoms resolve? Yes. So in long COVID, we have the people who may have symptoms during their acute infection, and those symptoms continue and develop into long COVID. We have people who, during their acute infection, resolve maybe some or all of their symptoms, but 5 weeks, 8 weeks, 12 weeks later, they're developing a new onset of symptoms. And that's not just in regards to headaches. If you look, again, I'm not trying to harp on this, but again, with long COVID being an umbrella term, if you look at the diagnostic criteria for ME/CFS, it's 6 months. If you look at the diagnostic criteria for POTS, it's 6 months. And a lot of that, let me back up, both of those are known post-viral illnesses, right? So we know that from experience and what we're seeing in the past with post-viral illnesses and what we're seeing with long COVID, that these symptoms don't have to be present at the immediate onset. And because of whatever stressors are continuing to occur in the immune system, that is what goes on to kind of trigger these ongoing additional conditions. So again, you can have this headache at the acute onset, which continues persistently, or you can have symptoms that resolve and then you develop this later. And again, not only symptoms that resolve, but there are also asymptomatic cases of COVID-19 that also go on to develop long COVID, which again encompasses migraines and headache conditions.
So there's a question by Jill. Is there any ongoing research on or data on whether an individual who never had migraine, much less headache, are now experiencing migraine after receiving the vaccine and never diagnosed with COVID? I'm not sure about ongoing research, but there's certainly observational studies, and I have a very small handful of patients that develop new daily persistent headache after a vaccination, and again, exceedingly rare presentation. One patient in particular is quite refractory. The majority of patients, their headaches have completely resolved, but took some time to get them to that place.
Yeah, agree. That has been my experience as well. I think it's pretty rare, but kind of in general, typically headache associated with vaccination are temporary. But yes, there has been cases of persistent headache after vaccination.
And then there's another question about the role of histamine in post-COVID migraine. I've certainly not seen those studies. I don't think those studies are available. It would be interesting to look at that. I think people think about histamines related to mast cells, and but you know, there's just like we need more studies on that.
Yeah, I was going to say that if you're interested in kind of the histamine response, you can look into some of the mast cell and long COVID research, which will list some of the symptoms that could possibly be associated, like headache. I do know that for me personally, my headaches are definitely somewhat contributed to when I have mast cell activation, like when I go through flares, when I'm out in the sun, or when I have a food intolerance from my mast cell. I know that it correlates with some of my headaches at times as well. So I think there's something there, but again, I think we circle back to we need research on so many different aspects of this.
And then Emily has a question. Do we think that other SARS infections could cause similar post-viral issues? I wouldn't just limit it to SARS infections. I mean, influenza infections. We have something called the International Classification of Headache Disorders 3, and it is one of, or a diagnostic criteria. So this is a phenomenon that we're seeing this much greater just because of the level of this pandemic, but it's certainly not new.
Right, correct. We certainly see that with other virus infection as well. So it's not just related to COVID or SARS infection. There's a question about sharing the studies with other neurologists. Yes, certainly we are trying to increase, like as Karyn has been doing, advocacy for long COVID syndrome or long COVID headache.
Yeah, that's why we're on. We're hoping that we have many patients on, but that we also have residents, people interested in studying this, or colleagues, or researchers that, the entire community hopefully is listening in. And this will also be posted on YouTube. So Jessica, I already have a new daily persistent headache and worry about getting COVID and my condition worsen short-term to long-term, or getting long COVID. I still wear a mask around others, indoor, no eating in restaurants. Do you recommend I keep this up? Well, Jessica, that's a great question. I think that you got to live your life and, get out there, and if anything, you can eat outdoors. It doesn't have to be indoors. So you can eat outdoors. Depending on where you are, whether you're wearing a mask or not, do get vaccinated because there's really no evidence that vaccination will worsen new daily persistent headache. I think that if you had your full set of vaccination, then, if you do get COVID-19, it's going to be generally a mild symptom and should be transient, even if you have underlying new daily persistent headache, because your type of new daily persistent headache may not have been viral, right? And so you got to get out there sometime and enjoy your life for sure. Common sense, you can start small and kind of move up from there. A lot of people have that question, so thank you for answering that. I don't know, Karyn, do you want to say something about that?
I'm very strong on to continue masking. I have to emphasize that the majority of long COVID cases were mild to moderate cases and not hospitalized that have resulted in many of these conditions and disabilities that people are facing. Yes, go out and live your life, but do it cautiously. Know what your environment looks like. If you can mask. And like, Dr. Monteith said, it's not even just COVID that can cause some of these longer term issues, but, there's neurovirus circling around and flu and all of these other conditions as well. So there is evidence that after COVID-19 infection, that there is immune dysfunction, and there's the possibility that you may react differently than you did prior to COVID to other secondary infections that you may experience afterwards. So my advice would be to mask where you can, and obviously for those that it's safe to do so, vaccinate, and your mitigation efforts really are unfortunately at this point on you to decide what is safe and not safe for you and your family.
Well, I would also add that, talk to your, all the advice we're giving you, talk to your doctors. Your doctors have to be involved. We're not your personal doctors. And so talk to your doctors. You may God forbid, if you have some type of immunocompromised state, then that's a different conversation, right? So engage your doctors. If you need a neurologist, engage your neurologist. If you feel like you need a headache specialist, the American Migraine Foundation has a wonderful search where you can look for headache specialists.
I think we have another question. Have you seen migraine increase over 1 year after COVID resolved that is not responding to triptans that used to? Yes, we have certainly seen different types of changes in headache characteristic, either increasing or decreasing, or change in headache presentation, location, symptoms after a COVID infection. And yes, some patients do report that the medications are no longer effective. So that's the time to discuss with your neurologist or headache specialist of switching to other medications. Yes, but changes of response to medications is commonly seen.
Yeah, and again, we need better studies. We need more observational studies that focus on migraine, because we know that sometimes triptans are not effective for some patients. They sometimes lose efficacy. It's great that we have expanded arsenal of treatments. Okay, so I know we're running out of time. I think we have one here. Do you recommend getting a second bivalent dose if you're under 65 years but suffer from chronic migraine?
I think overall we recommend getting COVID vaccination for protection, from overall health perspective. But I think for specific recommendations, I would recommend you to discuss with your doctors.
Great. Well, thank you so much. This was a very active chat. Wonderful presentations, both of you. And again, I would like to thank the American Migraine Foundation for hosting this wonderful webinar. I think it was very informative. And, thank you, Karyn, for all that you do, I think for patients, for the profession, and for, being part of all of these study sections that I know that you do. And Dr. Chiang, thank you for that wonderful presentation. It was very thorough.
Thank you so much. And thank you, American Migraine Foundation, for hosting this event.